Hello, good evening, Yogi. Welcome back for the part two of the case discussion. Yogi, are you there?
Yes, sir. Can you hear me?
Yeah, I can hear you now. So we'll start
Okay.
part two of the case discussion, diabetes in pregnancy. So I think other day we were discussing the different definitions, and also we were discussing the different screening methods and the importance of all of those things. So before we go on to the case discussion today, let us
Yes.
just continue with the importance of HbA1c, which is also, it is not exactly screening, but it is one of the follow-up type of measurements that we do. So before that, let us recap the quickly. So would you like to read?
Uh, yes, sir. So we were discussing about this 21-year-old homemaker whose obstetric score was gravida to para-1 living one. She had come to us at 29 weeks in view of her deranged sugars and polyhydramnios. So she was referred to as, sir. In this investigations, everything else was normal except her FBS was 108 and postprandial blood sugars were 156. At 28 weeks, her ultrasound showed an AFI of 24.6, which is polyhydramnios, and an estimated fetal weight 1.3 kg, which was also on the higher centiles. Her first pregnancy
Yeah. Is there an audio problem?
7 kgs at 8. Sir, is that true? I don't have an issue.
Yeah,
So can you
because
hear me?
your voice was cut. That's why I thought, okay.
Oh,
First
okay, sir.
pregnancy, LACS at 8 months.
8 months in view of PPROM and non-progressive labor. And she had delivered a live male baby of 3.7 kgs. Now the baby is doing fine. And her mother is a diabetic on OHA.
Okay. So let's go with the examination findings today. Okay,
So,
carry on.
so yes, on examination, her patient's height was 170 centimeters and her pre-pregnancy weight was 92 kgs, which brings to a BMI of 32.5 kilogram per
Yeah,
meter
so
square.
this itself gives us a suggestion that there is a possibility that she can develop GDM, because anything more than 90 kg and any BMI more than 30, right? Okay.
Falls on the high risk category. And there's no pallor, icterus, edema, and she was afebrile during examination. Her pulse rate was 80 beats per minute. It was
So
regular
all
in
other
rhythm and
findings are almost normal. Okay, we'll
yes.
skip this.
So on inspection, the abdomen was uniformly distended and umbilicus was everted. Linea nigrans stria gravidarum was present. The phalansteal scar was healthy. There were no dilated veins. On
I would like to
palpation, the
stop you
uterus.
here, Yogi. Suppose there was full-blown polyhydramnias, would there be any other description you would give?
So it will be stretched skin and shiny
Yes.
with
And
health. Some
suppose, okay, this is at the 29 weeks finding. It may not be
yes.
so bad, but suppose the patient was about term. What would be the
Yes.
description of the inspection? Abdomen is distended or over distended?
Abdomen will be over distended,
Yes,
sir.
very good.
With
Now, when it is over distended, where is the fundus and what else will be also full?
flanks will be full
Yes,
and the fundus will be up to Ziphi sternum, sir.
very
Usually
good.
at term it.
Very good. That's what we always say. If the fundus is at xiphisternum and if the flanks are not full, it is around 36 weeks, right? And when the
Yes.
flanks are full, it is term pregnancy. But whereas
Hmm.
if the fundus is at xiphisternum and flanks are full before that, then it is a
Hmm.
over-distended abdomen. In addition, you would also tell shiny skin, stretched skin, and all those things. Okay, so that is what we
Yes.
remember. But this was a 29 weeks finding,
Hmm.
so it may not be so over-distended and it may not be so tense and shiny. Okay,
Yes.
go ahead.
And on palpation, the uterus was already corresponding to 34 weeks. And fetal
Definitely,
parts were
definitely 4 to 5 weeks more than the period of gestation, isn't it?
yes, sir.
Suggesting that there is a possibility of macrosomia.
Yes. Yes, sir. So we come to a diagnosis that she's a gravida to para-1 living one at 29 weeks with previous LSES with polyhydramnios and gestational diabetes mellitus in present pregnancy.
But I'm sorry, Yogi, I would
Yes,
need
sir.
little more description here. This is a little bit incomplete, especially the palpation findings. What else would you like
Uh,
to add here?
so we can add the presentation that
Yeah,
she's 29.
usually, yeah, probably you didn't write because at 28, 29 weeks, we don't really bother about the presentation, whether it is cephalic or breech, because it may change, right?
Yes.
Is that the reason why you didn't really write that?
Yes, sir. It
Okay,
was variable.
fine. Yeah, okay. That is okay. I accept that. But if it's a term pregnancy, you have to say
Yes.
whether it is cephalic presentation or a breech presentation or whether it is any other oblique lie or anything like that, and which side is the back. What is the
Yes.
importance of knowing this? Which side is the back?
Sir, it is first to actually to place the NST CTG probe that we
That's
do,
all
and
right.
in the other, and the position also, sir. Like if it's LOT or ROT,
Yes,
it's
very
better
good.
to
Very good. So if the
design.
back is on the right side, most probably you can deduce that it would be a posterior position because ROP is the commonest
More
posterior position.
common.
Okay. One more thing,
Yes.
after palpation, I would expect you to have written
Hmm.
here. What is that? See carefully.
Auscultation.
Yeah, auscultation.
Auscultation.
So that is a definite miss here. Even at 28
Yes.
weeks, you have to write the fetal heart sounds and whether it is regular and all those things and the rate, actual rate you have to write. Probably it is
Okay.
in a hurry you have missed it. I'm sure you would have heard it. And fetal
Yes.
movements, of course, we usually ask the patient in the history and we palpate. This
Hmm.
is a must, especially during COVID times when we were not doing ultrasound and other things. So for every visit. So we were at least asking two questions, whether the fetal movements are felt, and we were just palpating and looking for the fetal movements. Okay. So these are the two things
Okay.
which will make it complete. I am just trying to correct for the benefit of you as well as for everybody. So the
Yes, sir.
examination finding has to be perfect and you
Okay.
cannot miss any things here. Okay. You have nicely
Okay.
described about the scar and scar is healthy. And there is, of course, right now there is no scar tenderness. But if it was a term pregnancy, you also should say there is no scar tenderness, okay? And it is continuous and all that. Where will you look for scar tenderness? Which area? Hello?
So sorry, I couldn't hear. Sorry, sir. There was a
Yeah.
network issue.
Which area you would look for scar tenderness?
So we used to look for 2 centimeter above the skin incision.
Yes. Yeah. So
So 2.
nowadays there is no problem at all because it's a fan and steel incision and the uterine scar also is just suprapubic. But in the olden days when I was PG, they used to put
Hmm.
the midline incision. And if you
Okay.
tell that it's a abdominal scar tenderness, you would get 0 marks. It's always we are worried about the uterine scar, which is transverse and low lying. Okay. So nowadays there is no confusion. It is almost coinciding there. But you must
Okay.
specify that I am looking for the uterine scar tenderness rather than the abdominal scar
Okay.
tenderness. Okay. So fine.
Okay.
So now let us get back into discussion. Now onwards, it is going to be pure discussion. We know the case. All right. So I was
Yes.
talking in the beginning of this class today. Let us continue
Hmm.
with uh, the investigations. Yes, other day we were discussing the sugar profile,
Yes.
but many centers, they also do HbA1c as a routine in all the 3 trimesters. Now, can you tell us
Yes.
what is the difference
Hmm.
between doing HbA1c in a non-pregnant situation and in a pregnant
Hmm.
situation?
Also, HbA1c, when we do it in the first trimester, it usually indicates our sugar control over the past 6 to 8 weeks, which is
Very good.
pre-pregnancy sugar.
Very good. Whereas in
So
second,
we
third trimester, what does it indicate?
in trimester it shows our compliance with the treatment and how she's been
Correct. Very
responding.
good. This is the major difference that we all have to understand. In a non-pregnant
Yes.
situation or in the first trimester when you do HbA1c, it talks about the previous 3 months control. Whereas in second and third trimester, if somebody is in the habit of doing HbA1c, it talks about the
Hmm.
current control or as you said, the control with the treatment. So can it be an indicator for anomalies? Let us just finish with the HbA1c.
Yes, sir. When it is very high, like about 10 in the initial
Very good.
trimesters, it
Very good.
shown for
And what are the other indicators of anomalies?
the initial high glucose, like RBS more than 200,
Yes.
and
Early growth
early.
delay. Okay, so as you correctly said, HbA1c very high, which is more than 10, is an indication that there could be anomalies. And in fact, some literature says if the HbA1c is very high in the first trimester, they advise medical termination of pregnancy also. Okay, but anyway, we nowadays have the ultrasound. We can do the anomaly scan and then only take a call instead of blindly going for MTP, isn't it? All right.
Yes,
So
sir.
now uh, we are now discussing macrosomia because this baby definitely has macrosomia and there is polyhydramnios as well. We know
Yes.
what is the reason for polyhydramnios. What is the reason for polyhydramnios?
So because there's going to be a lot of urine production from the baby in response
Correct.
to
Correct.
the hype.
Yes, it is the
So
production that is excess. That's why there is polyhydramnios. Also, there may be increased urination from the fetus, right? And
yes.
as far as macrosomia is concerned, when exactly it happens, in other words, we have to look at the fetal growth pattern, whether it is FGR or macrosomia. There's a three types of fetal growth pattern. You know, by chance, what are the three growth patterns?
So the initially it is hyperplasia,
Very good.
and then it's hyper and hyperplasia, and later
Yeah.
it's only hypertrophy.
Very good. So exactly, I'm very happy that you knew about this. So usually, whether it is FGR or GDM, it usually affects this part of the growth of the baby where there is hyperplasia and hypertrophy. So that's the time
Yes.
we will see either stunting of the growth or excess in the growth. Okay. So let's go
Okay.
ahead with the macrosomia. How exactly or why
Okay.
exactly macrosomia happens? Is it because of hyperglycemia that is transferred to the from the mother to the baby? Or some other reason?
No, sir. It is due to the hyperglycemia. Baby has hyperinsulin production. So in turn, it increases the insulin-like growth factors. So they
Very good.
cause the atrophy of the organs and
Very good.
increase subcutaneous deposition in the baby also.
Yes, insulin is after all like a growth hormone. So there is a direct transfer of insulin from there is no transfer of insulin as such, but there is transfer
Yeah.
of glucose. As a result, the fetal pancreas produces more insulin. There will be hyperinsulinemia in the fetus. And that is the one which will gives rise to accumulation of fat in the shoulder and other areas of the baby. Yeah. So this has to be clearly understood. There is hyperinsulinemia in the fetus. So that is the one which is giving rise. Also, there can be due to maternal free fatty acids, which are, yesterday you were telling how pregnancy is a diabetogenic state. There is free fatty acid production, isn't it, in the mother? So that is
Yes,
transferred
sir.
onto the fetus and there will be increased fetal triglycerides. So except for the
Okay.
brain, hopefully, because brain should not have fat, it should have all
Yes.
gray matter and white matter. Most of the other fetal organs are affected by this macrosomia. Okay, so good.
Okay.
So and then of course, uh, this macrosomia is different from large for gestational age.
Yes.
The what is the
Okay.
difference? Can you tell me?
Sir, I think LGA we see the AC is more, and the AFW will also be more. But in macrosomia, the head circumference will be on the higher side.
Not really. As we said, the brain matter is not really increased, or head circumference is not increased as such. Head circumference is always remains the same. But as you correctly said, yes, AC will be more in LGA, whereas in macrosomia, it is the fat deposition, okay, throughout the body except the brain matter. So this is the difference between large for gestational age and macrosomia. Okay, that's what we have to
Okay.
understand clearly. So now we have to manage the case. So let us look at the classification. When I was PG and later, we used to follow the Priscilla White's classification, which is
Yes,
into
sir.
diabetes A, B, and then so on, so forth. But now we don't follow that so much, but we follow a different type of classification. By chance, do you know this recent classification?
No, no, sir.
Okay, it's all right. Let me put it. It is a non-insulin dependent GDM,
Oh,
okay, which can
yes, sir.
be in low risk or high risk. And then there is
Okay.
insulin dependent diabetes without organ damage, Usually it means like ODM, okay?
Okay.
In Priscilla White's classification, she used to talk about, whether it has been long-standing, 10 years, more than 10 years, all those things,
Yes.
with organ damage, without nephropathy, cardiomyopathy, and all those things she used to talk. Now it is simply called as without organ damage, and which is stable or unstable, and then insulin-dependent diabetes with end organ damage. End organ damage
Oh.
means it's a long-standing diabetes, then she becomes
Mm.
pregnant. It is, in other words, ODM only, correct?
Okay, sir.
So,
Yes,
and
sir.
for a long-standing ODM. So there the patient will have more complications during pregnancy. So this matters. So we have to have a rough guidance about the classification. What are the
Okay.
complications of GDM? Because that matters, that way we are worried, isn't it?
So it could be maternal, fetal, and neonatal complications. So coming to maternal complication, antenatally the mother is prone for infections, and
Correct?
preeclampsia chances are also high, and complications of diabetes like diabetic ketoacidosis, hypoglycemia
Yeah.
can also occur in the mother.
Yeah.
And at term, she is prone for
Yeah, we are mainly worried
obstetric.
about the ketoacidosis part because, especially that's why exactly even if we have to give a steroid prophylaxis, we give in
Yeah,
divided doses. We don't give straight away 12 milligrams and all that. We give in 6 milligrams divided doses. And before
diabetic
giving steroid, we always check the GRBS. And if it is
sugars.
only less than 140, we give, isn't it? So here is the
Yes, sir.
mechanism by which the ketoacidosis happens because of lack of insulin. There is increased glucose production, which itself will give rise to diuresis, dehydration, and electrolyte loss. On the other side, as you said yesterday, there is increased lipolysis, so increased free
Mm.
fatty acids and ketone bodies. So this is giving rise to ketosis. So obviously, the treatment, if you reverse the arrows, you know the treatment. What's the treatment of
Sir.
ketoacidosis?
Insulin is the treatment with
Yeah.
along with
So
correction of.
yeah, so it is reverse the arrows, you will see the insulin lack. That's why ketoacidosis patients definitely require hospitalization. We have to remember this point when I ask you a question little later. Okay.
Okay.
So
Yes,
what
sir.
are the precipitating factors? Just now I gave one precipitating factor, that
Yes.
is steroid. What are the other
Yes.
precipitating factors of
Uh,
ketoacidosis?
so when the mother is starving or she's dehydrated, and then
Yes,
sympathomimetic drugs that we use for tocolysis, which we don't use it nowadays,
correct.
and again, steroids, and any new infection if she gets, and that can also be if in case of severe, and hyperemesis.
Yes. So as you correctly said, beta mimetic tocolysis and steroids that we give for lung maturity, for prophylaxis, and hyperemesis gravidarum, and
Yes.
unrecognized new onset diabetes. Sometimes, as we said, no, first recognized, only when we do sugars will we realize. First trimester she may
Mm.
be normal, second trimester she may be normal. Suddenly she can have in the third trimester, and the day we diagnose, she may be in ketoacidosis itself. So we have to be careful. So
Okay, sir.
other complications, maternal complications, you already said there could, because it's a part of dyslipidemia syndrome, there can
Mm.
be preeclampsia, polyhydramnios, which we are facing now in this particular patient. And because of polyhydramnios, last time she had a preterm labor, PPROM, isn't it? So that comes.
Yes, sir.
And then she can suddenly have hypoglycemic attacks. In fact, in diabetic patients, we are not only
Mm.
worried about ketoacidosis, we are also worried about treating very aggressively and pushing her into hypoglycemia. Sometimes
Oh,
intrauterine death can happen due to hypoglycemia rather than hyperglycemia. So
okay.
we have to walk a tight balance. That's why when in the rounds we used to ask the postgraduates, what is our sugar? We should not say what should be the sugar. You should not say less than 90. What you should be
Yes.
ideally telling.
The right value between 60, 80 to 90.
Yeah,
60
you
to
should
90.
not say less than 90. Less than 90 can be 20 also. So you must say
Yes.
around 95. Yesterday only we said, no. The best values, two
Yes.
values to remember is fasting should be around 100,
95.
95 to
Uh,
100, and the postprandial should be 120 to
one.
130. Okay, or 140 also you can give range. Don't say less than 120, less than 90 and all that. So in the diabetic patients, hyperglycemia is not welcome. Hypoglycemia is also not welcome.
Okay.
Correct? Okay, good.
Yes.
So going further with metal complications, intranatal complications, what are they?
So intranatal, she's a prolonged labor, and she can go in for shoulder distortion.
Yes, shoulder dystocia, and there can be soft tissue injuries, isn't it?
Hello, sir. Yes.
Soft
Yes,
tissue
sir.
injuries, because the baby is big and there can be lacerations, cervical tears,
Uh,
and all those things.
yes, sir. For postpartum, she's a high risk for postpartum hemorrhage and infections again in an instrumental delivery.
And there is an increased incidence of cesarean deliveries as well. Okay, so maternal
Yes.
complications, complete 2 slides we said. What about fetal
Yes.
complications?
So fetal complication, like starting from first trimester, the baby can have congenital anomalies, or it can go in for recurrent or like abortions, macrosomia, and it can have fetal distress, intrauterine fetal death also,
Yeah. So what are the
and
causes of intrauterine fetal death? I have mentioned 3 here. Do you know anything more?
um, hyperglycemia also. So, oh, that
Yeah,
is the
yeah, hyperglycemia, which will lead on to the
fetal.
atherosclerosis sort of a thing, which will give rise to hypoxia in the fetus. So that's the way it happens. Ketoacidosis, of
Yes.
course, the baby can die of that itself. And as I mentioned earlier, hypoglycemia can be the cause of death. So there are several ways by which the baby can die, and the death is
Mm,
sudden. That is exactly
mm,
why usually when we discuss later the management, especially the admissions, we should admit the patients at least couple of weeks before we plan to deliver, because this is a very
okay.
dangerous time. Sudden IUDs
Mm,
can happen. Okay. So in spite
okay.
of sometimes sugar control, because patient thinks that my sugars are under control, and she won't realize there can be sudden incidences of hypoglycemia. Yesterday you were talking about the transdermal cutaneous transcutaneous
Ye-
management, and there are sudden episodes of hypoglycemia, spontaneous
Yes.
hypoglycemia. So that is why we have to be very careful, right? What
Yes.
about, so the complications are never ending. After the birth also there can be complication, neonatal. What are they?
So sudden, immediate hypoglycemia will be there in the babies, and as then be birth injuries, and there'll be hyperbilirubinemia and polycythemia in case if it is a preterm baby, and there can be fetal macrosomia that will cause injuries, and like perinatal mortality is higher in babies with GDM
Yes,
mothers.
there are 3 hypos we say. One is hypoglycemia, hypocalcemia, hypothermia. Hypothermia because the baby is so big, the surface area
Yes.
is so big, and it is losing weight from that larger surface area. 2 hypers. One
Okay.
is hyperbilirubinemia and polycythemia. This is two
Sorry.
hypers. So 3 hypo and 2 hyper. Then, of course, respiratory distress syndrome is the most distressful. Even if you do cesarean section, as it is, the
Mm,
RDS incidence is more in cesarean section. With diabetic mothers, it is much more. All these things
okay.
will lead to increased perinatal mortality. So GDM will not leave the baby even after neonatal period. When the baby is
Yes.
child and adult, what are the problems?
So these babies are more prone for obesity, hypertension, and cardiovascular diseases due to
And,
dyslipidemia.
and later in life,
And
they
that,
themselves can
yeah.
develop type 2 diabetes. Okay. So whole
Yes.
lot of complications. That's why one
Mm,
has to be thorough with diabetic management, isn't it? So let's go to
yes.
the management. What are the 3 important tripod or legs of management of any medical disorder in pregnancy? Number one
So
is
any
management
fetal
of the
survival.
disease in hand. Okay, that is control of hyperglycemia in case of diabetes, control of hypertension in case of preeclampsia, control of anemia in case of anemia. So managing the disease proper. Okay. Second leg is
Yes, sir.
prevention of
Preventing
complications.
for
And third one is common for all cases, that is
fetal
obstetric
survival.
management.
Oh,
Obstetric management. Okay, so these are the 3 important aspects of management. So let us take up one by one. Okay, so obstetric management, of course, contains my famous 4 questions, which I always
yes.
discuss: when to deliver, how to
How
deliver,
to do
if you decided to
action.
deliver vaginally, should I wait for spontaneous onset or whether to induce labor? And if you have decided to induce, how to induce? Let us discuss that in the end. So let us now go
Yes,
to
sir.
the aims and objectives of antenatal care. What are they?
Also, first is to have a good glycemic control
Yes.
and to prevent complications of diabetes like ketoacidosis, macrosomia, and prevent her from getting infection, like causes that will lead to ketoacidosis, and look for the fetal surveillance, like any macrosomia, polyhydramnios, if any. So regular ultrasound monitoring.
Yes. And of course, as you said, we have to do the fetal well-being test right away from 30 weeks. And finally, Of course, this is a famous political statement, that is timely delivery. Every single case is a best answer is timely delivery. One who knows when to deliver is the king of obstetrics, isn't it?
Yes, sir.
Okay. Now let us go to the treatment of, first part is you said treatment of sugars or controlling of the sugars. So what do we have
Yes.
basically? We have basically diet plus exercise. This is like default I have written because diet and exercise should be prescribed for all women,
Okay.
irrespective of their sugars. This is common. After
Yes, sir.
that, what is grayed out here comes drugs. In the drugs, we have got OAD or
Oh,
insulin. So we'll go step by step. So what is the diet you prescribe? How do
so we
you decide on the diet, calorie wise?
so if she's a normal weight patient, we advise her around 30 kilocalories or 30 to 35 kilocalories per kilogram body weight. If she's less on the lesser side, we'll ask her 35, and if she's obese,
Yeah. So earlier in the part, we were discussing 30 is the sort of cutoff. If it is 30, then you can give,
percent carb and
yeah, with the normal BMI, 30
yes,
kilocalories.
sir.
So 25 kilocalories for a high BMI because we have to
High,
give less. With the low BMI,
yes,
we can actually increase it to 35. And what is the
but we
composition?
yes, sir. 40 to 50% of carbohydrates,
Yeah.
20% of protein, and the remaining 20% should be fat and more of unsaturated fatty acid and less than 10% of saturated fatty acid, and avoid frank sugars and avoid food rich in cholesterol and adequate fiber in the.
Very good. And of course, there's a big controversy regarding whether to give frequent small quantity of meals or not and all those things. Let's not go into details of that. She can basically have a normal diet as she has been having, except as you correctly said, don't add sugars. Okay. See, pregnancy is a very delicate balance. We cannot restrict diet so much also, isn't it? That
Hmm.
will push
Yes,
the baby into later problems of FGR. We should not go
yes,
to
sir.
drastic diets like less than 1,800 kilocalories. After all, mother
Yeah.
also needs energy. So it's a delicate balance. That's why we are discussing here what is the calorie and what is the composition. And direct sugar should be avoided. But once in a way, if she wants to, during baby shower, if she wants to have some sweets, she can have. But she has to monitor very carefully on that day, right? Okay. Now
Okay.
let us move toward, and exercise also cannot be very heavy exercise. She can just
Yes.
do a normal walking for 30 to 40 minutes, and she need not do heavy weightlifting and all those things. It is not possible. She has to be careful, especially with polyhydramnios. There's a chance of PROM, isn't it?
Yes, sir.
Yeah, and also yoga, she has to be very careful what she has to do and what she should not do. She should consult a expert in that. So these two
Yes.
being common, we are, as you correctly said yesterday only, you had told that we have to repeat the sugars after 2 weeks of diet, and if it is not
Yes.
under control, then it is
Hmm.
time to switch over to pharmacotherapy, and pharmacotherapy has got oral and injectable. So
Hmm.
let's go into that. What is the threshold for initiating pharmacotherapy?
Also, when the first GTT value is very abnormal,
See,
also,
the
and
old criteria, as I was talking about Priscilla White classification, there is A, B, C, and all that. A was further divided into A1 and A2. A1 was less than 105
105.
something. Yeah. A2 was more than 105. This is the
Yes.
old criteria. But the
Yes, sir.
new ACOG and ADA criteria, do you know by chance?
Uh, Sir, any value more than 200
That is
and
okay.
FBS
That is the random or the postprandial, but FBS is concerned
more
anything
than
more than
95,
90. Okay.
postprandial more than 1.
Yeah. And
2
2
hours
hours is 120.
is 1.
Yeah.
Yes, sir.
So if you want to remember just two values, these are the values to be remembered.
No,
I have been repeatedly telling 95, 95, 95 since yesterday. I hope everybody gets very correctly. Anything more than 95 and PPBS more than 120. And in
yes,
spite of diet and exercise, if it is still remains so, it's a time to start the uh, drugs, isn't it?
pharmacology.
Okay.
Yes,
Now,
sir.
whether to start metformin or insulin is the biggest question. How do you decide on that?
Sir, we usually start if the sugars are in the moderate range, we start with metformin. But
Yes.
if it is very starter, we admit her, do a sugar profiling, and then start her on insulin.
Yes. So nowadays, it is very, very clear. you can start metformin as a first line of therapy, especially patients who had PCOS in the past, or especially
Mhm.
patients who were controlled with the metformin. There is no need to start insulin. When I was undergraduate or postgraduate, we used to say you have to start insulin. But now, first line can be metformin or insulin. But usually we start with metformin because it is oral and it is very easy. Only if the patient is not controlled with metformin, or as you correctly said, if the sugars are very high, fasting more than 125, ppbs more than 200, then we may add insulin. I have written and
Oh,
or, isn't it? Metformin plus insulin, or you can straight away go for a insulin. Okay.
oh.
So, okay. What is the dosage of metformin you start with?
So we start with 500 in the morning,
Yeah.
and then we give it BD. We make it BD, maximum of 2,500 grams per day.
Yes, very good.
Oh,
So that is how we do it. Okay. And initially she
yes,
may
sir.
have a little bit of nausea and vomiting, but later she will metformin. See, what is the advantage of metformin over insulin at this juncture if we have to discuss?
Sir, it is easier for the better compliance for the
Very good.
patient. Let
That's
let
one thing.
come.
Any fetal advantage?
And sir, there's no. It is not transferred to the baby.
It is not transferred to the baby. One is that, and insulin, especially, there is studies have shown that though there is no transfer of insulin directly from mother to the fetus, whenever the patient is on insulin, there is a chance of macrosomia. But macrosomia is very less with metformin. That is another
Okay.
advantage that is told. So, what are the
Yes.
indication for hospitalization?
So when we are planning to start her on insulin, we admit and do sugar profiling. And if she has diabetic ketoacidosis, polyhydramnios, then we admit her. And if we are planning to terminate pregnancy, just as we said 2 weeks before the
Correct.
plan of
Very good.
delivery.
So, especially ketoacidosis has to be managed in the hospital only. And as also polyhydramnios, sometimes if she has got breathlessness and other things, we may have to do amniocentesis and keep her in the hospital for some time. Okay. And to plan the delivery and do the, close fetal monitoring, it is always better to admit her at around 37 completed weeks. Right. So, insulin
Yes,
therapy,
sir.
I will just try to finish in one slide. What is done in Manipal, we can just discuss.
Yes, sir. So we admit the patient, do a sugar profiling, and we start with the lowest dose possible. Injection, short acting atrapid, 4 units before breakfast, lunch, and dinner. We observe her for 2 days, and based on the sugar control, we then fix the dose. And that fixed dose is divided into a two-third dose in the morning and one-third in the evening. We discharge her with that dose, but we
Yeah.
keep ask her to do
Yeah.
sugar
What is the
monitoring.
rationale behind this mixed start 30, 70, two-third, one-third?
Sir, it coincides with the endogenous insulin production. It is
That
more
is
in the
called
morning.
two peaks and two plateaus, right? So when you
Yes,
give
sir.
two-thirds in the morning, it will take care of the morning peak, and the mixed
Yes.
start, the 70 will take care of the plateau. And in the evening, you are giving one-third, a shorter peak happens in the night. So it will be taken care of by that. So this is the basis for giving mixed start. So to prevent
Yes, sir.
complications, we have to avoid infections
In
and
stressors and avoid
yeah,
any stress. Then treat any infections, again, urinary infection and vaginal infection, and any other complaints that she has during pregnancy, like dental caries.
yes. Now we have come to the third leg of the management. We have finished with the management of sugars. We have finished with the prevention. Now comes the obstetric management. Answering the four questions. When to deliver?
So if she is well controlled sugars with a diet or OHAs, then we can go till 39 weeks, sir, and
Yes,
allow
why
her
this
for.
39 weeks?
So the
Why not
chances of
37? In preeclampsia, we say 37.
uh, yes, sir,
I have written in the bracket.
reduced incidence of RDS
Yes,
after the
because as we just discussed a little earlier, in
yes,
diabetes, there's a chance of RDS. And after 39 weeks, according to literature, the incidence of RDS is almost nil. That's why, if
okay,
possible, under your direct care, strict control and strict monitoring of the fetus, you can
yes,
try
sir.
to deliver around 39 weeks. Next question is how to deliver?
Yes, sir. Depends
Depends.
on the yes, sir,
Yes.
fetal and the
Yeah,
medical.
your particular case is also a case of previous cesarean section. So, and this time, if there is a big baby, now already it was 135 or something. Now it is at term, it will be big. So
Yes,
you may
it
tend to do a cesarean section. And since she's a second gravida, you may also try to do sterilization if she is completed the family. We have to counsel for
Yes.
that. So wait for
Yes.
spontaneous onset of labor. Answer is no.
So in
We
no, definitely.
usually either do section or we induce and deliver her around 39 weeks because at any cost, we should not allow them to go post-term. There can be
Yes,
chance,
sir.
big baby, shoulder distortion, all those things, isn't it? So how
Yes,
to
sir.
induce? Of course, it depends upon the Bishop score. And now we have got better inducing agents, isn't it?
Yes.
So what are
Yes,
the
sir.
indications for section?
Sir, your big baby, of course, more than 4 kg, macrosomia, and
Yeah,
previous
big
LSA.
baby, don't have to always say 4 kg. You have to
Okay.
always match with the mother. Sometimes 3.5
Yes.
itself can be a very big baby. I have seen some obstetricians getting into trouble for waiting up to 4
Mm.
kg, which is a Western standard. So then you get into
Okay.
trouble. So you decide based on the ultrasound findings, based on the mother, based on the pelvis, based on previous section, so many other factors. Okay, right.
And other, if she developed other complications, like she's a preeclampsia is also there in this pregnancy. Then if she
Yeah.
previous LSC,
Yeah, the
fetal
others
distress.
are mainly obstetric conditions like, malpresentation, CPD. These are all usual conditions. Okay. So how do you manage the labor? Suppose you have decided to give her vaginal delivery. How do you manage the labor?
So, patient is asked to skip her morning dose of insulin or
Very
OHA,
good.
and we do frequent sugar monitoring every 2 hours, and we put her on normal saline. And if the sugars are less than 120, we only
You
give
can,
normal saline. If
instead
it,
of normal saline, what we do in Manipal, we can also put her on 5% DNS with the 6 units of neutralizing insulin in that.
yes,
Okay.
sir.
So when we give
Yes,
5% dextrose, we calculate it and say 6 units is required to neutralize whatever sugar is there in that. And the idea is to maintain 72 to 126. This is according to latest ACOG and NICE guidelines. Okay. Yeah.
okay, sir. And we have to check continuous fetal monitoring with CTG is done, and every 2 hours we check for her blood sugars, and every 4 hours we check for urine ketones as well. And follow the progress, and a partogram is strictly advised. So we follow her for any prolonged labor or anything. And
Yeah. And third stage active management and prevention of PPH also there. Post delivery.
so post delivery, again, the insulin requirement will drastically come down. So we need to strictly monitor her sugars and titrate those doses accordingly every 2 hours. And then on post of day 2 and 3, we check her post dinner and the day 3 morning sugars, and then decide on continuing or discontinuing her OHAs or insulin. And then 6 weeks later, we call her for a GTT.
Correct. Very good. So I think you have done extremely well, Yogi, and we have not gone into much details of the management. However, we have broadly decided. By chance, if I remember correctly, her EDD was April 17th or so. Uh,
Yes, sir.
has she delivered?
Uh, the patient has
Yeah.
and she had a little baby, and both the mother and baby are doing fine.
Oh, that's good to hear. So has she undergone sterilization?
Yes, sir. Like actually, in spite of explaining the high risk that the baby is preterm, mother wanted sterilization.
Oh, okay. What was the birth weight?
4040, sir.
Oh, at what gestation you said? I just missed that.
36 plus weeks, sir.
Oh,
36 plus
36
4.
weeks itself, she was 40. That means definitely she was uncontrolled initially. That's why I want to, again, in last 1 minute left, I want to reiterate that the the treatment should start as early as possible. That is exactly why all the 3 trimesters we must do sugars at least once. And we should know because by the time she was referred to you already, there was macrosomia set in, polyhydramnios was set in. No wonder she was almost 4 kg at the 36 weeks. And good that you took her for section and gave her a live baby. And of course, you also did sterilization. She has got 2 good babies. All the
Yes,
best
sir.
to you, Yogeshwari, for thing. And we will continue with the case discussion series. You are the leader who is